Ladies and gentlemen, the subcommittee will come to order. Chairman will recognize himself for an opening statement. Today's hearing will provide an opportunity for members to discuss the federal medical assistance percentage, or FMAP, rate. The FMAP is the federal statutory financing formula that is the basis for determining the federal government's financial share of most Medicaid and Children's Health Insurance Program expenditures, CHIP. While exploring the FMAP may seem like a dense topic to some, today's hearing allows members to look under the cabinet to examine Medicaid's plumbing, how money flows throughout the system. It is important for members to understand how the FMAP works because it impacts how an estimated $545 billion in program expenditures will be spent this year. Federal law specifies the formula for calculating federal medical assistance percentages and requires the Secretary of Health and Human Services to calculate and publish FMAP rates each year. The statutory formula compares individual states' per capita income to the nation's per capita income in order to determine the portion of Medicaid expenditures the federal government will finance in each state. The lower a state's per capita income, the greater the assistance the state receives from the federal government, so the higher the state's FMAP. Federal statute specifies that the basic Medicaid matching rate for states will go no lower than 50% or higher than 83%. Medicaid has used the basic FMAP formula since its creation more than 50 years ago. Since the creation of the Medicaid program, Congress has, over time, created several different levels of federal financial participation, or federal matching, for different services, benefits, and populations. These higher levels of federal matching are exceptions to the general FMAP. For example, since 1970s, the federal government has paid 100% of services furnished through Indian Health Services and tribal facilities, and 90% for family planning services and supplies. These exceptions are higher than any state's regular FMAP and apply uniformly to all states. Today, we will be discussing numerous other exceptions to the regular FMAP. In recent years, Congress has twice increased FMAPs across the board to provide temporary fiscal relief to states during recessions. Most recently, Congress added a new level of increased federal matching through the Affordable Care Act's expansion of the Medicaid program to non-disabled childless adults. For new expansion states, the Affordable Care Act included a matching rate of 100% for the expansion population through this calendar year, after which federal matching levels decline over time to reach 90% by 2020 and remain at that rate at least under current law. I should also point out that the FMAP also serves as the basis for determining the federal government's share of expenditures for the Children's Health Insurance Program, CHIP. Section 2105B of the Social Security Act stipulates an enhanced FMAP rate for both services and administration under CHIP. The EFMAP rate reduces the state share under the regular FMAP rate by 30%. Additionally, the Affordable Care Act increased the EFMAP by 23 percentage points, not to exceed 100%, for fiscal years 2016 through 2019. As a result, the federal government is now financing 100% of the CHIP programs in 12 states. Overall, I think today's hearing presents members with an important opportunity to better understand the FMAP rate that is hardwired into the heart of the program. I also hope members will grapple with the challenges created by the current FMAP formula, including the ways that the current patchwork of federal matching arrangements impacts the integrity of the federal and state cost-sharing relationships. Today, we have one panel of knowledgeable experts from CRS, MACPAC, GAO, and HHS-OIG who will present their ideas and recommendations on these issues and answer members' questions. I appreciate each of the witnesses being here today. And yield back, bounce my time. Now recognizes Mr. Schrader of Oregon for opening statement.
Thank you, Mr. Chairman. I'll probably reserve most of my comments and for the question period, but willing to yield some time to Mr. Lujan.
Mr. Chairman, thank you so very much, and to our ranking member, I really appreciate the time today. I care deeply about these programs. As we see the impact to people all across America, this landmark program makes a difference in the lives of the poor, our seniors, people with disabilities, and truly provides them the peace of mind that they can access affordable care without fear of financial ruin. We have to be mindful of that. 1 in 3 children in our country receive coverage through Medicaid, and the Affordable Care Act's expansion of this program is strengthening coverage throughout the United States. In my home state of New Mexico, more than 250,000 people have benefited from the ACA's Medicaid expansion. In New Mexico, we have also recently seen what happens to people when they can't receive the care that they need. More than 2 years ago, New Mexico's behavioral health system was needlessly upended by the state when they suspended Medicaid payments to 15 providers. This resulted in disruptions and gaps in patients' care. On Monday, just a few days ago, or just 2 days ago, 10 additional providers were cleared of fraud. In total, 13 have now been exonerated. This manufactured crisis, which has impacted some of New Mexico's most vulnerable, never should have occurred and left our behavioral health system in shambles. It takes decades to build a strong system of care in New Mexico's largely rural, underserved areas. Where sole providers become vital to the fabric of our community, those relationships and developing that trust with patients is critical, and we have to rebuild that system now. To achieve that goal, I'm finalizing a bill that would encourage states like New Mexico to make the necessary investments in their behavioral health systems when Congress asked states to update and modernize their infrastructure for enrollment. We provided states with an enhanced FMAP to do just that. If we want states to invest in behavioral health, we should provide an enhanced federal matching rate to prioritize these investments. The United States has never supported mental health in this way, especially with the expansion of Medicaid across the country. We must ensure that states continue to improve their capacity to provide mental health services. I look forward to the testimony and to discussing how we can use FMAP to strengthen our behavioral health system. And with that, Mr. Chairman, I would yield back the balance of my time to Mr. Schrader.
Thank you very much. Anyone else on the Democratic side? Ms. Matsui.
Thank you very much for yielding, and I thank the witnesses for being here today and the chairman for having this hearing. For the past 50 years, the Medicaid program has successfully improved the ability of low-income Americans to access essential health services. Today, more than 72 million Americans depend on Medicaid and CHIP for their health insurance. The vast majority of these enrollees are children, the disabled, or the elderly. In addition to improving health care access, Medicaid is notable for its program efficiency. Medicaid provides more comprehensive benefits than private insurance, and it provides those benefits at lower out-of-pocket costs. In addition, Medicaid per beneficiary costs are lower than per beneficiary costs for Medicare and private insurance, and those costs are growing far more slowly than either Medicare or private insurance. The Medicaid program continues to improve its efficiency as demonstration projects allow the states the flexibility to test new models of delivery that improve program value. Instead of talking about ways to reduce Medicaid, we should be talking about ways to strengthen Medicaid, to expand coverage, to improve quality of care, and in turn, improve health outcomes for millions of Americans. Thank you, and I yield back to Dr. Schrader.
Anyone else on the Democratic side? Mr. Plum? Oh.
You'll get your full time.
Oh, that's right.
okay.
Mr. Plum, then maybe Mr. Sarbanes an opportunity, then you'll get
Oh,
your
yeah,
full time.
sure.
That's right. Mr. Sarbanes.
I'll be very quick. I'm looking forward to the testimony. I had the opportunity for about 18 years as an attorney to work with retirement communities, nursing homes, assisted living facilities in the state of Maryland, and saw how critical the resource of Medicaid is for our seniors. And so keeping this program strong and also exploring opportunities to innovate with it and figure out how the program can support seniors in a number of different settings as we move forward, and the opportunity to do that in a way that can also save some of the costs and be efficient, I think, is something we want to explore. So it's a really important program, and this particular formula for funding it has worked overall very well. So we look forward to your testimony so we can understand that more and think about the potential for future development of the program. I yield back.
Yield back our time, Mr. Chair.
Chair thanks you, gentlemen. Now I recognize the Vice Chair of the full committee, Ms. Blackburn, 5 minutes for an opening statement.
Thank you, Mr. Chairman, and I want to welcome you all and thank you for being here. This is an issue that we continue to look at and to review, and it's appropriate that we do. When I'm at home and in my district, one of the things I hear about most often are the efficiencies and the inefficiencies of working through the Medicaid delivery system, which in our state is TennCare. You all probably know it and know the stories of TennCare well. What we need to do is we continue to review these funding formularies and the mechanisms. Transparency is important, continued oversight is important, integrity in the program is something that is important. I think another thing that's a topic for discussion as we look at the formulary and what the basis ought to be is saying, is it time to give Medicaid back to the states for the states to administer this program? That is another way to look at it. And we'll be interested to hear your thoughts on that. Many of our governors and many of our state elected officials would like to see us do that. They think they could be more efficient. And Ms. Matsui mentioned the opportunity for some to innovate in their states. And yes, indeed, looking at new flexibilities that allow innovation is something that, you know, maybe we need to have greater discussion about that. So welcome to all of you, and thank you. And Mr. Chairman, I will yield to Mr. Shimkus. It looks like is seeking time. Yield to Mr. Shimkus.
Thank you. I appreciate my colleague from Tennessee. I'm just going to throw something on the table. I've got questions later on, but Mr. Chairman, I was visited by a delegation of businessmen from Puerto Rico last night, and they have, and I just want to raise this because I think for the average member, this financial crisis is, we're now starting to at least know a little bit about it. But since we're on Medicaid, I was told that they have a $300 million cap on spending. They're not in the Medicaid system. They don't have FMAP. And there is an impending cliff coming in April of 2017 that I think is worthy of our attention and maybe a hearing and a discussion, because if what I was told was true, it's an impending additional disaster for that part of our country that really doesn't have a voting member of the House of Representatives. So with that, I will throw that out and I'll yield back to my colleague.
Thank the gentleman. Anyone else seeking time before I yield it back to the chairman? Mr. Chairman, I yield back.
Chair thanks the gentlelady. I recognize the ranking member of the full committee, Mr. Plone, 5 minutes for an opening statement.
Thank you, Mr. Chairman, and thanks for holding the hearing and for the witnesses for being here today. I believe the government exists to help all Americans succeed, and improving and strengthening Medicaid for generations to come continues to be a primary goal of mine. Medicaid is not a welfare program, it's a health insurance program that more Americans depend on than any other single federal health program. In fact, Medicaid provides more than 1 in 3 children with a chance at a healthy start in life, and 1 in 7 Medicare seniors are actually also Medicaid seniors. The truth is, the overwhelming majority of the more than 71 million Medicaid beneficiaries are children, the elderly, the disabled, and pregnant women, all our most vulnerable populations. Medicaid was designed at the federal level to expand and contract according to a state's need, and that is a tenet we must protect and improve, not reverse. And despite the incredibly complex nature of its shared federal and state financing, Medicaid is an efficient program. Its costs per beneficiary are substantially lower than private insurance and Medicare, and in recent years, these costs have grown far more slowly. The facts also show that Medicaid has a lower improper payment rate than many of our federal health programs, all of which cover less people. Every single state Medicaid program has undertaken projects testing new models of care delivery that promote quality and value in the Medicaid program. In fact, the Medicaid program is often called the Innovation Incubator. So as we learn more about Medicaid's financing structure, or FMAP, today, let's think how to build on these efforts. That's the right way to promote a value-based Medicaid program for the future. FMAP may not be perfect, but merely looking at baselines, growth factors, and state contributions ignores the most critical issue, which is providing care in the most efficient way possible to some of our most complicated populations, the tens of millions of low-income vulnerable beneficiaries that rely on Medicaid and the healthcare providers and plans that serve them. I yield back, unless someone else, I think our other members have all had an opportunity, Mr. Chairman, so I yield back.
Chair, thanks to gentlemen. That concludes the opening statements. As always, all members' written opening statements we made a part of the record. We have one panel with us today, 4 witnesses. Let me introduce them in the order of their testimony. First of all, Allison Mitchell, analyst in healthcare financing, Congressional Research Service. Thank you for coming. Secondly, Dr. Ann Schwartz, Executive Director, Medicaid and CHIP Payment and Access Commission, MACPAC. Thank you for coming. Carolyn Yoakum, Director, Healthcare Government Accountability Office, JO. Thank you for coming. And John Haig, is it? Haig, Director of Medicaid Audits, Office of Inspector General, U.S. Department of Health and Human Services. Thank you all for coming. You will each be given 5 minutes to summarize your testimony. Your written testimony will be made a part of the record. So at this point, Chair recognizes Ms. Mitchell, 5 minutes for her summary.
Chairman Pitts, members of the subcommittee, thank you for the opportunity to appear before you today to provide an overview of the Federal Medical Assistance Percentage, or the FMAP, and the exceptions to the FMAP. Medicaid is financed by both the federal government and the states, and the federal share of Medicaid expenditures is determined by the FMAP. The FMAP varies by state, and it has a minimum of 50% and a statutory maximum of 83%. And for a state with a 60% FMAP, the state gets 60 cents back from the federal government for every dollar it spends on its Medicaid program. The FMAP is also used to determine the federal share of other federal programs, such as the Temporary Assistance for Needy Families contingency funds. And the FMAP is also used to calculate the Enhanced FMAP, or EFMAP, which determines the federal share for the State Children's Health Insurance Program, or CHIP. The FMAPs are calculated annually, and they vary according to each state's per capita income. So states with high per capita income receive lower FMAP or matching rates, and states with low per capita income receive higher matching rates. Currently, in fiscal year 2016, regular FMAP rates range from 50% in 13 states to 74% in Mississippi. And the EFMAP used by CHIP is higher than the regular FMAP, and it is determined by reducing the state share under the FMAP by 30%. And for fiscal year 2016 through 2019, there's a 23 percentage point increase in the EFMAP. That means the current statutory range for the EFMAP is 88% to 100%, and in fiscal year 2016, 12 states are receiving that 100% EFMAP. The per capita income amounts used in the FMAP formula are equal to the average of the 3 most recent calendar years of data from the Department of Commerce. This helps to moderate the fluctuations in states' FMAP rates over time. Also, the per capita income amounts used to calculate the FMAP rates are several years old by the time the FMAP goes into effect. The FMAP is impacted by each state's income and population relative to the national average. The impact of a national economic downturn or upturn on a particular state will be related to that structure of that state's economy. The FMAP changes from year to year for most states, and these changes are often within 1 percentage point. However, even these small changes can have major budgetary implications. The exceptions to the regular FMAP have been made for certain states, situations, populations, providers, and services. There are currently more than 20 exceptions to the FMAP. Some of these are quite old, and some of them are newer. For instance, since the beginning of the Medicaid program, most administrative services have been matched at a 50% for all states, and starting in the 1970s, certain services provided to Medicaid enrollees at Indian Health Service facilities have been reimbursed at 100%. Also, the District of Columbia's FMAP rate is not determined according to the statutory formula. It is set in statute at 70%, and that has been the case since 1998. And the Patient Protection and Affordable Care Act added a couple of new FMAP exceptions. The main one there is the FMAP for the matching rate for the newly eligible individuals under the ACA Medicaid expansion. For these individuals, states receive 100% matching for 2014 through 2016, and that phases down to 90% in 2020 and subsequent years. The federal share of Medicaid expenditures used to be about 57% on average across all states in a typical year. However, with the exceptions to the FMAP added by the ACA, this has increased, and in 2014, fiscal year 2014, the federal government paid about 60% of Medicaid expenditures on average across all the states. This concludes my statement, and I would be happy to answer questions at the appropriate time.
Chair thanks the gentlelady. Now recognize Dr. Schwartz, 5 minutes for your summary.
Good morning, Chairman Pitts and members of the Subcommittee on Health. As MACPAC's Executive Director, my testimony today...
Can you pull that microphone a little bit closer?
As MACPAC's Executive Director, my testimony today reflects the consensus views of the Commission itself, anchored in a body of analytic work over the past 5 years, and we appreciate the opportunity to share MACPAC's views this morning. At the request of the leadership of this subcommittee and your colleagues in the Senate, MACPAC is engaged in a long-term work plan focused on advising Congress about policies and financing reforms to ensure Medicaid sustainability. To date, we have focused on documenting trends in Medicaid expenditures, looking at the drivers of this spending, and considering the incentives created by the current system of financing. As others have already described, state Medicaid programs receive federal funds to match the funds they spend on health services to Medicaid beneficiaries, and this financing arrangement goes back to the program's very beginnings 50 years ago. Today, the federal share is determined by the FMAP with higher matching rates to states that have lower per capita incomes relative to the national average and vice versa. There are exceptions for certain populations, providers, and services. Spending for administration is generally matched at 50%. CHIP has its own match rates, known as the enhanced FMAP, which are substantially higher than those under Medicaid, in some cases at 100%. At various points in the program's history, congressional and regulatory action have increased the FMAP for specific activities. For example, to help execute certain program functions, such as implementation of modernized eligibility and enrollment systems, to create stronger incentives for states to provide optional benefits, and to encourage states to expand eligibility to optional groups, such as women diagnosed with breast and cervical cancer. Enhanced match has also been used to provide fiscal relief to states during economic downturns or when affected by disasters. In addition, increasing the federal match can allow Congress to make policy changes without imposing additional costs on states, for example, as was the case with the required increase in payments to primary care physicians in 2013 and 2014. As others on the panel will note, this system of financing has been criticized for providing open-ended amounts of federal funds and for not incentivizing states to be efficient. Moreover, it can encourage states to broaden Medicaid to include other health activities where possible in order to draw down federal funds. On the other hand, these incentives, while strong, are not absolute. States may not claim federal share unless they spend state dollars raised from legal sources on activities that are legally matchable. Mindful of their own budget constraints, as well as other political and economic factors that shape their healthcare markets and the design of their Medicaid programs, states respond differently at different times and in different circumstances. So let me provide a few examples. States do make informed choices about the design of their programs, and thus they don't always take up the opportunity to draw enhanced match. Section 2703 of the ACA provided authority for people with chronic, for states to create health homes integrating care for people with chronic conditions and mental health conditions, and it provided a 90% federal match for 2 years. And fewer than half of the states have done so, with only 20 states in the District of Columbia adopting the model as of December 2015. Second, because states must raise state share, they do not always take advantage of all federal dollars that are available to them. In the case of CHIP, of the $21.1 billion in federal funds appropriated for FY 2015, only $11.3 billion was provided to states in allotments based on their prior year spending. In addition to the other criticisms on the matching formula that will be discussed by others on the panel, I would add several other concerns that MACPAC has identified. First, the differential between the federal match for services and administration exerts downward pressure on states' willingness to invest in activities such as measuring utilization and quality, collecting and analyzing data, and ensuring program integrity. In the 37 states where health services are matched at greater than 50%, states can increase their total Medicaid budget by prioritizing spending for services over administration. The federal government does provide enhanced matching funds for some administrative activities, but enhanced match is not available for others that could improve efficiency and promote value. For example, the differential between the two match rates creates a disincentive for states to focus on prevention of fraud and abuse. Such functions are matched at 50%, while activities of a Medicaid fraud control unit, which are aimed at detecting fraud and abuse after they have occurred, are matched at 75%. Over the next several months, MACPAC will be focusing intensively on program and financing and design question. Our analysis will consider design questions and will also consider the impact of these approaches on states, plans, providers, and beneficiaries. We look forward to sharing this work in our June report.
Chair thanks the gentlelady. Now recognize Ms. Yoakum, 5 minutes for her summary.
Thank you. It's a pleasure to be here today to discuss the Medicaid formula and GAO's work surrounding this issue. As we've talked about, the FMAP formula is based on a state's per capita income in relation to the national average. And it is over a 3-year period, which smooths out the fluctuations in the business cycle and focuses on longer-term trends. This is helpful to states in terms of their budgets and budgetary planning with the FMAP. In prior work, we have noted concerns regarding how FMAP formula allocates funds across the states, including during times of recession or economic downturn. My statement today focuses on the FMAP and options for more equitably allocating Medicaid funds across states, and then also better targeting increased assistance to states during an economic downturn. With regard to the more equitable allocation of Medicaid funds across states, per capita income is a poor proxy for states' fiscal capacity, as well as for the size and composition of a state's population in need of Medicaid. First, per capita income does not fully measure state resources. It includes some things like wages, rents, and interest, but it does not include other resources such as corporate income. Second, per capita income does not take into account differences across the states and the healthcare service needs of low-income people, nor does it include any measure of geographic difference in the cost of providing such services. As an alternative to per capita income, GAO has identified 3 measures that could be used to allocate Medicaid funding more equitably. 2 of these measures account for service demand, and they also account for geographic cost differences. This improves equity among beneficiaries by ensuring that the level of services across states have the ability to offer a comparable level of services for each person in need. The 3rd measure accounts for state resources, and this improves taxpayer equity by ensuring that taxpayers in poorer states are not more heavily burdened than those in wealthier ones. These 3 measures could be combined to provide a basis for allocating Medicaid funds in a more equitable manner than what currently occurs using the FMAP. With regard to targeting increased assistance to states during recessions and other economic downturns, Congress has acted on multiple occasions to provide states with temporary increases in the FMAP. Such assistance is important, for during economic downturns, Medicaid enrollment often increases while available state revenues decline. At the request of Congress, GAO was asked to consider methods of assisting states during economic downturns. We recommended that Congress consider enacting an FMAP formula that provides automatic, timely, and temporary FMAP assistance to states in response to an economic downturn. We developed a prototype formula that would automatically start and end assistance, and it would target the amount of such assistance based on the extent to which each state is affected by a particular downturn. Our prototype formula uses a monthly employment to population ratio, and it begins when a threshold number of states experience declines in this ratio. This automatically triggers the start of the FMAP assistance, and once triggered, the assistance is calculated based on two factors. First, on increases in state unemployment. This serves as a proxy for changes in Medicaid enrollment. And then secondly, for decreases in wages and salaries, and this serves as a proxy for declines in available state revenue. Ending the temporary FMAP would be based on the employment to population ratio, but with the ability to gradually return states to their regular FMAPs. In conclusion, our work has found that alternatives to the current FMAP could more equitably allocate funds to states and provide additional support during economic downturns. This concludes my prepared statement. I'd be pleased to answer questions at the appropriate time.
Chair thanks the gentlelady. Now recognizes Mr. Hagg, 5 minutes for his opening statement.
Good morning, Chairman Pitts and other distinguished members of the committee. Good morning, Chairman Pitts and other distinguished members of the committee. Thank you for the opportunity to testify about the Office of Inspector General's work associated with the federal medical assistance percentage matching rates. My statement describes two vulnerabilities associated with the federal-state partnership that governs the financing of the Medicaid program. First, in certain areas of enhanced matching rates, OIG has seen states claim federal reimbursement for expenditures that do not qualify. Second, in some instances, we have seen states use financing mechanisms to shift costs to the federal government. I will briefly discuss each of these issues. Most Medicaid expenditures are eligible for federal reimbursement at the regular matching rate. The regular FMAP rate varies by state and, as said earlier today, cannot be lower than 50% or higher than 83%. There are numerous exceptions, however, that allow for the use of enhanced rates. For example, family planning services are reimbursed at a 90% FMAP rate. Enhanced FMAP rates provide states with additional federal funding for specified populations and services, but they also create vulnerabilities that expenditures could be claimed incorrectly. The OIG has conducted audits to determine if expenditures were included in the correct enhanced rate categories. In general, we have found instances where states incorrectly claimed expenditures in one of the enhanced rate categories instead of properly claiming the expenditures at the lower regular FMAP rate. As an example, we have found many cases where states used the 90% enhanced family planning rate for services that were Medicaid eligible but did not qualify as family planning. In total, we identified more than $82 million that states received inappropriately. In addition to vulnerabilities that exist with enhanced FMAP categories, the shared nature of Medicaid financing provides opportunities for states to shift cost and distort the federal-state cost-sharing partnership. While mechanisms such as provider taxes, intergovernmental transfers, and inflated payment rates increase state funds, they distort statutorily determined FMAP rates and undermine the federal-state partnership in financing the Medicaid program. In a 2014 review of healthcare provider taxes, we found that a gross receipts tax on Medicaid managed care organizations in one state appeared to be an impermissible healthcare-related tax under federal requirements. Using this tax, the state obtained nearly $1 billion in federal Medicaid funds from 2009 to 2012. CMS issued guidance to states in July 2014 to clarify its policy. We are currently performing work to determine if states are in compliance with this guidance. State policies that inflate federal costs for Medicaid are not new. In a series of reports from 2000 to 2005, we found numerous examples in which states used intergovernmental transfers to increase the amount of Medicaid expenditures the federal government would pay. In some cases, states transferred the additional federal money to their general treasury to be used for other purposes. Both Congress and CMS took action to close this loophole. While the changes dramatically improved the situation, they did not entirely eliminate the problem. Collectively, the findings of our work over a number of years suggest that improvements are still needed to safeguard federal Medicaid funds, including a definitive regulation linking payments for public providers to the actual cost of providing a service. In conclusion, the federal and state governments share responsibility for operating the Medicaid program and for the integrity of the dollars invested. Given projected growth in Medicaid, it is critical that CMS and states focus on strengthening program integrity. OIG is committed to providing effective oversight to help ensure that any inappropriate payments are detected and that eligible beneficiaries receive the needed and appropriate health care services. I would be happy to answer your questions.
Chair, thanks, gentlemen. That concludes the opening statements of the witnesses. I will begin the questioning and recognize myself 5 minutes for that purpose. Ms. Yoakum, GAO has offered alternatives for allocating federal Medicaid funding in a more equitable way. Can you explain how GAO considers equity when thinking about the Medicaid funding formula, and can you explain how or why some states are advantaged and others are disadvantaged by the current FMAP formula?
Yes, we look at equity from two perspectives. The first is that of the beneficiary and making sure that the state has the capacity to provide the same level of services across all the states. It doesn't mean that the state chooses to, but it does mean that that capacity is there. And then secondly, we look from the perspective of the taxpayer. And so that you make sure that a wealthier state is not paying more or less than a poorer state, that it's in relation to what's available for the state to fund the program. With regard to advantages and disadvantages of the formula itself, yeah, right now the floor, as I believe Dr. Schwartz mentioned, the 50% floor of the FMAP does mean that some states are propped up with more assistance than they might need. To date, no state has reached the top of the matching rate. There also is some research out there that shows that the matching formula is slowly, there's been more and more compression to that 50% level. So it's a mixed bag for the states.
Thank you, Dr. Schwartz. Almost a year ago, I, along with Chairman Upton, Chairman Hatch, asked MACPAC to engage in developing policy options to ensure the sustainability of the Medicaid program. However, it was not until MACPAC's most recent meeting a few weeks ago that staff even briefed the commissioners on old Medicaid ideas from the 1980s and 1990s. With all due respect, why has this taken so long? What could be more important than developing solutions to strengthen Medicaid and CHIP?
Thank you for that question. We began our discussion of financing alternatives actually beginning in February of last year with a session to discuss a range of alternatives. And in that particular session, we spoke a lot about shared savings. Subsequent to that, we spent time at every commission meeting since then, May, September, October, December, and again, as you say, in January, focusing on spending trends, helping understand the context, understanding the policy levers that are available to state and federal governments to address concerns about spending and to understand the drivers of that spending. So I have a long list of activities that we've undertaken, some issue briefs that we've published, the work that is leading up for a publication in a report to Congress in June, and I'll be happy to share that with you and brief your staff in detail about those activities.
All right, thank you. Mr. Hagg, your testimony noted that multiple Inspector General audits found repeated state errors in claiming the 90% enhanced family planning match And as a result, OIG recommended that 19 states return more than $82 million to taxpayers. Was this money ever returned?
I believe it has been. Our reports are issued to the states. We make recommendations to the states, and if we found overpayments, we would recommend they pay that money back. CMS, as the action official, would work with the states to get that money back, assuming CMS concurs with our recommendations, and I think in most cases they have.
Do you know why CMS didn't catch states' errors in claiming federal financial participation before the claims were paid?
Not definitively. CMS has different controls in place. They could probably more fully answer that question as to why they wouldn't. Based on what I know, they have staff located throughout the country who receive expenditures from the state on a quarterly basis. They're the front line for trying to review and identify any problems that might be out there. But of course, it's billions of dollars, and they have a short amount of time to.
Maybe part of the problem could be a lack of specific federal statutory and regulatory definition of what family planning services are. Ms. Mitchell, the Speaker, the President, and members of the House have noted the financial crisis in Puerto Rico. Mr. Shimkus earlier mentioned Medicaid in Puerto Rico. Can you briefly discuss how Puerto Rico's program compares or is different than an average state's Medicaid program?
Sure. So Puerto Rico and all 5 territories, the Medicaid program is financed a bit differently. Rather than the open-ended funding that states receive, the territories get caps on their funds, so they have an annual cap. And the ACA provided some additional funding that's available to the territories, and I believe that was the fiscal cliff that was referred to earlier is due to that funding. It was about $6.5 billion. And the territories have through 2019 to spend that money, but it looks like Puerto Rico is going to spend through that faster than that. And their matching rate for the territories is set at 55%. It does not go through the statutory formula for the FMAP.
Thank you. My time's expired. Chair recognizes Mr. Schrader of Oregon, 5 minutes for questions.
Oh, thank you, Mr. Chairman. I appreciate that. Ms. Mitchell, would you say that the rates for Medicaid reimbursement are primarily cost-based?
Sorry, could you say that?
The rates for that are set for Medicaid reimbursement are primarily cost-based?
The provider rates?
Yes.
Well, states set their own provider rates. They have a lot of discretion in setting their provider
No, I apologize. No, I'm talking about when you reimburse a state, it's based on the costs that are submitted by the state. Is that correct?
Yes, I'm sorry. Yes. So there's a quarterly process where states, for every quarter, submit estimates on how much they're going to spend. And they're provided an amount of money to draw down throughout the quarter. And at the end of the quarter, they have to submit documentation for their actual expenditures.
I get that. Ms. Schwartz, do you think that's a good way to reimburse, just based on cost rather than quality or what they're actually getting for the type of service that you're paying for?
I guess, as I noted in my testimony, that the FMAP, with the exception of the exceptions, is neutral on the type of spending, and you could certainly move to a system in which you valued certain services higher. It would be complicated, but it's an area that could be tested in a smaller scale. I think doing that nationally would be exceedingly difficult across the many populations and the many services that Medicaid program.
And I think that's why we have a number of waivers, so that each state can figure out what program probably works best for them, although as long as it's sufficiently audited, I think. Ms. Yoakum, I'm actually concerned about your report. Your report focuses on paying more for costs, and I think it's going to be a big additional cost to the United States taxpayer. The geographic diversity is purely cost-based. Where's the geographic diversity in your report regarding better quality of care in certain parts of the country versus other parts of the country for the dollars that are actually spent? That would be of, I think, great interest to the consumer, both the person getting the health care as well as the taxpayer.
Yeah. Our report does focus on geographic differences, and to a certain extent, state spending itself reflects some of those differences.
But that just reflects the cost. It doesn't reflect what you're getting for that. Is that correct?
That is correct.
Okay.
Yeah.
I think that's a problem, Mr. Chairman and members of the committee, that we need to be focusing on. Say what you will about the ACA, but regardless of that, I think the focus of healthcare going forward in our country is going to be about getting bigger bang for the buck. The reports from OIG and GAO, I think, try and get at that in some ways, but I think they're a little outmoded. Nowadays, for healthcare, we need to be looking at better ways to do things. The coordinated care model pioneered in my state and several other states, I think, is something I'd like to see some of these reports start to focus on. It is complicated. The formula proposed by Ms. Yoakum is also pretty complicated if I look at it closely. So I'd like to look at that quality part of the reimbursement. Mr. Haig, given some of the uses of the Medicaid dollars you've identified that don't seem to fit the classic category of Medicaid services, does CM kind of a play on what the chairman's talking about? Does CMS Medicaid actually have adequate revenues to police the program?
Well, that's a big job for sure. You know, as I said before, CMS could probably provide a better answer about the resources they have and the way they use those resources right now to oversee state expenditures or additional resources they might need. You know, at the base level, I know they have staff located throughout the country who receive the state expenditures on a quarterly basis. They're the front line for the first review. But again, we're talking about, you know, hundreds of billions of dollars and a short amount of time that they have to review those expenditures.
So it sounds like they could use a few more dollars. What, out of the, you know, 5 or 6 recommendations you make, are there 2 or 3 you'd like or think Congress should particularly focus on in working with CMS to review?
Well, specifically, if you're talking about trying to make sure expenditures are in the correct enhanced FMAP categories, bottom line, it really comes down to states doing a better job and taking better care and making sure that those expenditures are claimed appropriately. It's the state's job to do that. There's no way that, you know, CMS or any oversight is going to be able to get to every single error that might be out there. So states need to know their responsibilities and make sure that they claim properly. From CMS's standpoint, it probably would be good for CMS to try to reinforce with the states what the state's responsibilities are, so the states clearly know the importance of properly claiming.
Very good. With that, I'll yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the Vice Chair of the full committee, Ms. Blackburn, 5 minutes for questions.
Thank you, Mr. Chairman. Ms. Yoakum, I want to come to you, and I thank you for being so persistent and consistent in coming to us. Let's go back to the formulary issue. And looking at the FMAP, I want to hear from you. When you look at the per capita or the total taxable resources, what do you think is the better option, and why would that option be your choice?
From GAO's perspective, total taxable resources is a much better indicator of a state's available resources to finance the program. I just looked at this yesterday, and there's about a 40% difference between the total taxable revenue and per capita income. So 40% more additional spending is included within total taxable resources. And what happens is you have inequities across states in terms of what's reflected in the per capita income. States with a lot of people who work in one location and live in another, those kinds of things don't always get counted in the correct manner. Corporate gains and corporate taxes, and then also high energy states is another area where the allocations aren't necessarily consistent.
Okay, thank you for that. Let's talk about additional assistance that's sometimes available during an economic downturn and how that affects a state, and what might, how might that affect a different, how would that affect the state's incentives, and how would, how should we approach that? Because you want to be helpful, but you don't want to be have a system where they're dependent on this and just say, oh well.
Right. Well, states, since in the 50-year history of the program, have always been in a bind during an economic downturn. People lose their jobs, their children at least, and sometimes the adults qualify for Medicaid. So you have an increase in Medicaid enrollment. And then along with that, tax revenues go down because it's a recession or a downturn. So they have more people in the program and less money to pay for it. One of the advantages of a federal-state partnership is the federal government offering that balancing of those circumstances.
Let me ask you this. States that have accessed those funds, how quickly, once the economy recovers, how quickly do they go about removing those individuals from the rolls?
It honestly varies a great deal. And probably the hardest part of any kind of automatic assessment, adjustment like we're talking about, is when to turn off the assistance. Unemployment tends to be a lagging economic indicator, so recovery can be slow.
All right.
Yeah.
Thank you for that. Ms. Schwartz, MACPAC has publicly supported the extension of the enhanced federal matching rate for Medicaid eligibility systems. Talk to me about the criteria that MACPAC uses for assessing whether to support an enhanced federal matching rate. Just if you'll quickly articulate that.
Sure. In our letter commenting on that rule, the criteria that compelled the Commission in that instance to be supportive of the continued enhanced FMAP were that the FMAP rate would be tied to concrete performance standards by the state, and that these would improve the eligibility and enrollment process, both from the perspective of the beneficiary and from program administrators, who would enhance data collection and reporting and improve administrative capacity. And I think this enhanced rate also recognizes that Congress already approves enhanced match for mechanized systems, and increasingly enrollment and eligibility processes, which would have once been largely administered face-to-face, are now mechanized systems as well. So those are the criteria used.
Okay, thank you. Yield back.
Chair thanks, gentlelady. Now recognize the gentlelady from California, Ms. Matsui. 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Schwartz, I want to ask you about long-term care and FMAP enhancements. The majority of seniors and people with disabilities want to remain at home to receive long-term services and supports instead of going to a nursing home or institution. Research demonstrates that this is more cost-effective, yet despite some success, many states lag behind in providing services at home because of Medicaid's institutional bias, where nursing home coverage is mandatory and home and community-based services are optional. Congress has passed several FMAP incentives to fix this problem, such as Community First Choice, the Balancing Incentive Program, and Money Follows the Person. Some have expired or will expire soon. I believe this committee should absolutely be having a conversation on reauthorization of these programs, which are overwhelmingly bipartisan. Dr. Schwartz, how well have those FMAP incentives worked?
The Balancing Incentives Program was focused on targeting states that had that spent less than half of their long-term services and supports money on home and community-based services to help them make the shift from facilities community-based services. And states were invited to submit a budget and a plan for how they would do that. Of the 17 states that had participated in the first quarter, 11 exceeded that threshold. It's not possible for me to say whether it was the enhanced FMAP that did that or some of the other supports that were provided as part of that program. And states may continue to make progress towards their goals even though the enhanced match has expired. In addition, states have many other avenues by which they can shift service from nursing facility to home and community-based services, both through state plan options and through waiver services. So there are a variety of approaches that states can take and tailor to their specific needs and populations.
Can you comment on further recommendations you'd have to improve upon the incentives that we have to states to ensure that people can remain at home?
MACPAC has not made a recommendation on creating a financial further financial incentive to do that. We closely monitor what's going on in the long-term service and support space. Very encouraged by the shift to home and community-based services, which is both fiscally promising and also responsive to patient and family needs and desires. And one area where we're closely monitoring is the move to manage long-term services and supports, which we are still learning about, and we still are looking forward to some of the outcome measures about how that shift is going.
Thank you. I think we all realize how much interest there is in long-term care delivery, especially among a population that is growing, and with families wanting to, in some way, accede to the wishes of their parents. And so I think it's something where long-term delivery in this country, which Medicaid is the single largest payer, deserves a lot of our attention on this committee. Ms. Yoakum, the committee has been very interested in GAO's proposal for automatic trigger. I think the idea of making the FMAP even more responsive to the state's needs is a worthwhile discussion. I have a couple of additional questions to clarify this proposal. Why does a prototype formula focus on providing increased assistance during national economic downturns and not regional downturns?
Sure. The big issue with a regional downturn is it's not always regional. For example, if there's an energy, if there's a recession that's associated with energy, it can be spread across states all the way across the country, from Alaska to Texas to Wyoming and so on. And it's much more difficult to think about targeting a small group of states like that. So our focus has been more on the national downturn.
Could we look at that a little bit more? Because I'm thinking about our recent recession. Much of it was caused by the housing crisis, and there are certain areas of the country that was really hit harder than others. And I think if you look on a map, you can kind of identify those areas. And I think if you look at and I'm just saying that I think that's something to look at, because I think if we wait to look at the national model, we may miss those really hard-hit regional areas.
Yeah.
Something to consider with any discussion of the winners and losers of the policy, whether some states may benefit more under policy than others. And I think to a certain degree, we're talking about this when I talk about the regional downturns. So what type of variation can be seen with the enactment of your emergency trigger proposal?
Well, there is a lot of variation. That's maybe the bad news from your perspective. The good news is the variation is very dependent on which states are affected by the downturn. And it changes from recession to recession. In our work, we looked at 4 different downturns and the differing effects that happened on states. So while one state may not get an additional FMAP, it would be because they didn't need it that particular time.
Okay, well, thank you very much.
Chair, thanks, gentlelady. Now I recognize the Vice Chair of the Subcommittee, Mr. Guthrie, 5 minutes for questions.
Thank you. Thank you for, Chairman, for calling this hearing. I know it's a very complex financing system we have, and I think a couple of things. One, I know that states, it appears, what Mr. Hack, you've found is that are just improperly billing. Another thing is just trying to find ways to maximize the way the FMAP formula works in ways that probably we didn't intend, but it's not necessarily wrong on their part. But in your testimony, you did note that provider taxes, intergovernmental transfers, and upper payment limits have had the effect of distorting the FMAP rates and quote, undermine the federal-state partnership in financing health care. While this is a longstanding concern of the OIG, can you comment on what degree you think this distortion may have increased in recent years, given the budget challenges states are facing?
Well, we haven't studied the extent to which those mechanisms have increased in recent years, so I don't know definitively. I think it's safe to say, at least generally speaking, what we see specifically involving healthcare provider taxes, I think those have been on the rise in recent years.
And Ms. Yoakum, do you have any comments to shed light on that question?
I can't give you a specific number. I do know that our work has shown an increase in provider taxes and an increase in supplemental payments, and these can be used to have an influence on the amount of federal money that's received.
Thank you for that. And then, Ms. Yoakum, I have a question for you as well. I've been interested to learn more about the assistance distributed under GAO's prototype formula. Am I correct that this prototype formula would have been less costly than the assistance provided through the Recovery Act?
Yes, you are. We tested it over several recessions, and it ranged from providing $9 billion in assistance to about $36 billion, which was under the big recession. The reality is, though, that the Recovery Act was attempting to do more than make Medicaid whole. They used Medicaid as a vehicle to provide additional state support.
Okay. And am I correct in understanding that if Congress were to implement the prototype formula compared to current law, not the Recovery Act, but current law, this change would need to be offset since it would increase federal outlays during a downturn?
I believe so. You would really have to work with CBO on that. They're the experts.
But it appears to be. And Dr. Schwartz, when MedPAC presents this committee with recommended, when MedPAC presents this committee with recommended changes to the Medicare program, it routinely also provides the committee with recommended policies to adopt to offset the changes. Unfortunately, MacPAC does not offer ideas about ways to offset Medicaid or CHIP changes. If MacPAC wants us to be able to move forward on your recommendations, wouldn't it be, why doesn't MacPAC mirror MedPAC's practice?
Excuse me. To that point, I would first note that a number of our recommendations have had no budgetary impact, and in that case, a no saver would be needed. We are now engaging as part of our work on children's coverage in particular, and the work that we would be doing for you on financing, looking to see what kinds of saving options might be out there. And we do always try to work with CBO in understanding the fiscal effects of the recommendations, and that has certainly affected the Commission's decision-making when considering different options.
Okay, thank you. And I'll just close with this kind of statement. And I was in the state government in Kentucky, and we do a biennial budget. So just general revenue budget. My first one was the year 2000, so for 2001 and 2. And our biennial budget in Kentucky is about $13 billion. That's not exact, but it's close. And since then, talking about the strains on state budgets, since then, I mean, we've cut universities. There are a lot of strain. And I think last year's biennial budget was close to $19 billion, so it's gone up a third in a decade, a little over a decade. And so it's been consumed a large part. There's other things, drivers of the debt, but a large part of it's Medicaid. And so as these states are looking, I think, for opportunities to maximize FMAP and to make their budgets balanced, it's just Medicaid is continuing to consume more and more of what our federal deficit and more what states do. So this is helpful for us so we can get a handle on this. If we don't, there's going to be no discretionary money at states to spend in educating our children, and it's going to be difficult for us to ever get our budget balanced if we don't do so. So your information today has been very helpful, and I appreciate that very much.
Chair, thanks, gentlemen. Now I recognize the gentleman from New Mexico, Mr. Lujan, 5 minutes for questions.
Mr. Chairman, thank you very much. As we all know, Medicaid is a lifeline to so many. But as I noted in my opening statement, New Mexico's behavioral health system is in crisis as well. I described the upheaval that has resulted in the Susana Martinez administration going after so many of these providers. And as I stated earlier, just on Monday, 10 more of those providers that had allegations against them of fraud were exonerated. And contractors were brought in from outside of the state to take over a system. The current infrastructure was dismantled, and we need a lot of support there. But with that being said, during the New Mexico delegations, many conversations with CMS on the crisis and its impact in New Mexico, we, the delegation, asked CMS to provide us with data that CMS was receiving from the state of New Mexico that they are collecting from them. We hope that the data could provide us with something insightful, with a better look at what was happening on the ground and not happening on the ground. Unfortunately, after months and months of delay, the response that the delegation from New Mexico received from CMS was that CMS admitted that the state-provided data had, and I quote, significant limitations. This left CMS largely unable to determine which, I quote, areas and populations may be experiencing decreases in utilization. So the data being collected right now, at least from the state of New Mexico, is not able to help anyone make any decisions. So without access to meaningful data, how is it possible for the people of New Mexico or us here to make decisions, and how can people hold policymakers accountable? Without access to meaningful data, no one can know if enough is being done to ensure that the most vulnerable are protected. And without access to meaningful data, we can't determine how best to strengthen the program for the most vulnerable. That's why I'm interested in determining how we can use FMAP to help states build out and prioritize behavioral health infrastructure, data, and access. So, Dr. Schwartz, if we want states to build and maintain strong behavioral health systems, are there ways we can use FMAP to do so?
I would say first, to the point of data, the issue of data is one that MACPAC has consistently noted concern about the need for data for many purposes, for program integrity purposes, for the purposes of improving value and monitoring quality and improving quality. And this is an area where CMS has been working to change its system to something called the TMSIS, the transformed MSIS, which has been going much more slowly than anyone would have anticipated. There are many things that states could do to strengthen behavioral health systems. Of course, states might prefer enhanced FMAP. States have many options in the types of benefits that they can provide in behavioral health, and there's wide variation in how they do that. They have a wide variation in how they structure their systems in terms of the providers that they have, their use of managed care for behavioral health. So there's a whole range of strategies. MACPAC's work at the moment is trying to look at whether there are barriers and how whether those barriers are in the practice environment, the state environment, or the federal environment for integration of behavioral health services with physical health services. Because for many of these populations, regular contact with a physical health provider is their major point of contact with the health system.
And so you answered the next question that I was going to pose, which was if you could speak how Congress has used FMAP to incentivize states to prioritize healthcare delivery systems. And one of the areas that it seems that enhanced FMAP has worked is the long-standing family planning enhanced match, which appears to have drastically improved Medicaid access to families. But with that being said, the bill that I'm working on provides an enhanced FMAP to states that prioritize investments in infrastructure, access, and data collection. I'd be curious to hear what types of suggestions you have about the interventions that are important that would maybe be most successful to help this program.
Be happy to take a look at that for you and get back to you on the details of it. There may be some technical assistance that we can provide in that regard.
Appreciate that, Dr. Schwartz. And Mr. Chairman, thank you so much for this important hearing today, and I yield back the balance of my time.
Chair, thanks, gentlemen. Now I recognize the gentleman from Illinois, Mr. Schempius, 5 minutes for questions.
Thank you, Mr. Chairman. If Graham would put the slide up. Every time I deal with a Medicaid debate, of course, Ms. Yoakum, you've seen this numerous times. The red is what the CBO would say is the mandatory spending. The blue is the discretionary budget. When we have a budget fight and there's a threatened shutdown, it's on the blue that the fight is about. So this is a simple question, but it's one that we hear out in the district. We use that term mandatory, or we use the word for portions of the red, not all of them, as entitlement spending. Anyone want to comment on those two words as good words or bad words to use? Ms. Mitchell? I mean, what should they be called? Are they good?
I don't know. I mean, I don't know that I'm qualified to answer that.
Okay,
but entitlement meaning that, Medicaid is an entitlement, meaning that both the states are entitled to Medicaid funding and individuals are entitled to Medicaid coverage. So that means there's no cap and states cannot put on.
And that makes it mandatory because they're entitled to the coverage.
Yes.
Dr. Schwartz?
Yes, all these.
These are, you might find like a goofy
No, I think the label.
talk, but it's really, it's out there. People get confused. And if we're trying to deal with what Mr. Guthrie was talking about, the national debt, part of the national debt is our promises to pay entitled people with mandatory spending.
The labels are all extremely value-laden, but you point out correctly that when states spend money on these services that are authorized within the statute on populations who are entitled to those services and deemed eligible by those states, those funds flow through, and the federal share is mandatory. It's not subject to an appropriation.
Great, thank you. Ms. Yocum, did I fairly accurately talk through that?
Yes, I think your statement is accurate. Yeah.
Mr. Haig?
I'm not sure I would have anything new to add. Obviously, Medicaid's a very important program for the people that receive their health insurance through it. It's a tremendously important program to them.
Right, but this is a 2014 pie chart of $3.5 trillion of federal spending, and then again the discretionary portion is anywhere between $1 trillion to 1.2, and the rest is, as you've identified, entitled or mandatory payment to meet the entitlement. So I appreciate that. I want to go to we had a discussion. In fact, Mr. Lujan also mentioned this 90% enhanced family planning match that we've discussed based upon it. So I'm going to go, Mr. Haig. Does the OIG have the capacity to continually audit all states' claimed federal matching for family planning services?
No, we don't have that capacity.
Given that the Medicaid program is a shared federal-state responsibility, and given OIG's limited resources, is it fair to say that states have a responsibility to do audits and prioritize oversight where there are known vulnerabilities?
Yeah, I think that's fair to say. It starts with the states. The states have the responsibility to make sure that the expenditures that they claim are accurate. In the case of family planning or other enhanced FMAP categories, that the correct expenditures are in those categories.
Great, thank you. And Dr. Schwartz, in your testimony, you noted one concern with the FMAP is that states have an incentive to broaden Medicaid to include other state health functions where possible in order to draw down federal funds. Can you elaborate and give an example of what you mean?
I think when state resources are tight, there are incentives to look for other sources of revenue, whether it's for school-based services, transportation, or public health services. From MACPAC's perspective, our focus has always been on looking for policies to make sure that the eligibility decisions are made correctly, that the services are provided to enrollees are medically necessary and appropriate, and the providers meet the federal and state participation requirements.
So states are dipping into Medicaid dollars for other services that may not be appropriate based upon the definition of Medicaid. They're gaming the system.
That's the distinction I want to make. And I'm sure that the gentleman from the OIG may speak to this as well. From MACPAC's perspective, when states claim federal match, those services must be legally matchable from legally sources of revenue, even if they are provided in different settings.
And that's your recommendation. My follow-up, your recommendation is that they follow that?
Yes.
Okay, that's it. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentlelady from Illinois, Ms. Schakowsky. 5 minutes for questions.
Thank you. Thank you, Mr. Chairman. The importance of Medicaid just simply can't be overstated. I want to start with that because just yesterday, the CDC released new data showing that states that have expanded Medicaid have an uninsured rate of 10% for adults age 18 to 64, probably still too many, but yet, compared to an uninsured rate of 17.3% for non-expansion states. However, many states, including my home state of Illinois, receive FMAP rates very close to the statutory minimum of 50%. In fact, Illinois receives an estimated 3.1% of annual FMAP funding, but covers 4.8% of the nation's Medicaid beneficiaries. And I'd like unanimous consent to enter into the record a document prepared by the Illinois Hospital Association, which highlights the importance of Medicaid to Illinois.
Without objection, so ordered.
It is well known that Medicaid payment rates are low, especially compared to the payment rates of Medicare and private industry, private insurance. The need for adequate payments to Medicaid providers is incredibly important in providing stability in our healthcare system and ensuring access to providers for Medicaid beneficiaries. States have the flexibility of providing supplemental payments to providers, and I believe this flexibility should be maintained. So, Ms. Schwartz, let me ask you, while some of the testimony today has focused on supplemental payments made to providers, I'm more concerned about ensuring that providers receive adequate payments for services provided under Medicaid. Are underpayments to providers a systemic problem in the Medicaid program?
I think on the physician side, the literature has really consistently shown a relationship between fees and physician participation. And when fees are lower, physicians are less willing to participate, and therefore the potential for access problems. The lower rate that Medicaid generally pays for physician services relative to Medicare is also well documented, and that was part of the thinking behind the primary care payment increase in 2013 and 2014. On the hospital side, it's significantly more complicated because states can pay hospitals through many different mechanisms, including their base payment rates, non-DISH supplemental payments, and DISH payments. The degree to which total payments to hospitals in the aggregate varies considerably across states. And we don't know a lot about hospital-specific payments. And for that reason, MACPAC has recommended 2 years ago, and more recently in the DISH report that we released on February 1st, that we need more data to better understand how hospitals are being paid. We recommended that the Secretary collect and report hospital-specific data on all types of Medicaid payments that they receive and on the sources of the non-federal share, so we can determine net Medicaid payment and we can help answer the kinds of questions that you're raising.
I'm sorry, what happened February 1st, did you say?
On February 1st, MACPAC released a statutorily required report to look at Medicaid payments to disproportionate share hospitals.
Okay, thank you. States, including Illinois, use intergovernmental transfers, or IGTs, to legitimately, I believe, fund their Medicaid programs. Medicaid statute, since its inception, requires states to use state general funds to pay for 40% of their share of Medicaid funding. States are afforded flexibility to fund their portion and draw down the federal share. In addition, many states use provider assessments to ensure stability in their Medicaid programs. Without provider assessments, Illinois' Medicaid program would cover less than 70% of the cost for Illinois hospitals to care for the state's most vulnerable populations. So, Ms. Schwartz, is there a component of these legitimate payment mechanisms that, I mean, isn't it really the states and the providers that are willing to put up their share and shifts the burden really to them, a burden that they're willing to accept, which I see as a good thing?
I guess just to build on what I said previously, states are allowed to use intergovernmental transfers. We know much less about those intergovernmental transfers than I think we would like to know, and that is part of the rationale for our recommendation to collect more data on that. We've been relying on some work GAO did that is illustrative of the issue, but not nearly as comprehensive that you would need to make a significant policy change in that area.
But isn't it sort of obvious that if the state's ability to creatively finance their Medicaid programs are further restricted, that it would lead to cuts in services and benefits for the beneficiaries?
It's hard for me to predict how states would react. States may have other sources, and I couldn't comment on the specific reaction that states would have to such a change.
And so you're looking more carefully into this, and when do we expect to know something?
Well, I think legislation is needed for the Secretary to collect those data.
I yield back.
Chair, thanks, gentlelady. Now,
I'm sorry,
go
sir.
ahead.
I just need to correct what I said. The Secretary doesn't need legislation, but the Secretary has been reluctant to, and therefore it might be wise on the part of the Congress to actually direct the Secretary to do that.
Chair, thanks, gentlelady. Now I recognize the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you very much, Mr. Chairman. Ms. Yoakum, I have tremendous appreciation for the work that GAO does to evaluate policies and advise the committee. However, I am concerned that the current process for appointing commissioners for MACPAC may be fundamentally flawed. For example, the MACPAC statute explicitly allows for Medicaid directors to serve on the commission. However, there's not one single Medicaid director serving on the commission today, but Medicaid is supposed to be a federal-state partnership. So I ask, why hasn't GAO put someone on the commission who is actually running a Medicaid program today?
Sir, I know that the Comptroller General is working on a response to the committee's request, and I'd like to defer until that comes to you.
I appreciate that. And Dr. Schwartz, I got to tell you, as an attorney, I'm very troubled by an apparent conflict of interest from some of the commissioners. Having read Ms. Rosenbaum's reply to Chairman Upton and Pitts, I have to tell you it was unsatisfactory in my judgment. In my opinion, when you read that letter carefully, it is a clear conflict under legal ethical standards that the chairwoman, even though she wasn't chairwoman at the time, would sign on to a case adverse to the House of Representatives when she is a sitting MACPAC commissioner. Doesn't matter whether she was chair or not at the time. And when you look at her letter, you know, not only is she an attorney, which is clear in the letter, but she goes on to state that this case that she got herself involved in is the focus of my life's work. It's so core to her that that is her number one concern. If that's not the appearance of impropriety or a conflict of interest in the standard legal definition, I frankly don't know what is. And then she goes on in her letter to say, but now that I'm chairwoman, I'm not going to do any more work on that case. Well, if she has a conflict now as a chairwoman, which she feels means she shouldn't work on that case, she shouldn't have worked on that case in the first place. And the issue is not resolved in the conflict of interest issue, but it's also not exclusively her problem. One of the current commissioners sits on the board of a nonprofit which is involved in legal advocacy and has been involved in at least one class action suit against a state Medicaid program. Now, I've got to tell you, I can't see how these are not conflicts of interest in the sense of, I understand there's a financial conflict of interest people talk about. I'm talking about a judgment conflict of interest in the legal standards as an attorney. One of them is not just that you have a direct conflict, but that there's an appearance of impropriety. There's an appearance of impropriety. And I think that it's ought to be of concern, and y'all ought to be disturbed at MACPAC that you didn't anticipate that this would be a problem for the public and for members of Congress. We need, as Congress, we need objective recommendations for strengthening Medicaid and CHIP. Given the concerns that the committee leaders have raised, I hope you understand my worry that MACPAC recommendations will be viewed as somewhat tainted, that there may be some conflict in there, and that we can't rely on that as we ought to be able to as credible or objective in all cases. Now, you know, I know folks are good people, and I don't know Ms. Rosenbaum, but when you look at her letter, this is my life's work. That's a sign of a good person. But in this case, there was a mistake made, an appearance of impropriety, and she shouldn't be doing both her life's work and filing briefs or amicus briefs in opposition to the United States House of Representatives. As members of this committee know, and as others who have followed me through the years know, it is not a new position for me to recommend that we change the way we do things, and that perhaps these appointments ought to be made directly by Congress. I plan to introduce a bill that will make MACPAC directly appointed by both parties. It's not a partisan bill in that sense. Both parties, majority, minority, would get appointments. House and Senate would get appointments. And I believe that that's a proper way for us to proceed going forward. I look forward to working with folks to try to make that better. If they don't like the way we have the numbers configured, that's obviously something that can be discussed. But as a legislative advisory panel, we need to know we're getting the right stuff and that people don't have conflicts so steeped in their own personality that they would write a letter back to us and in defense say, but this is my life's work. I yield back.
Chair thanks the gentleman. And recognize the gentlelady from California, Ms. Capps. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to the panelists for your testimony today. While I always appreciate the chance to talk about the importance of Medicaid and CHIP to both families and communities, it is critical that any proposed changes do not undermine the program's important role in our healthcare safety net. Unfortunately, we continue to see plans from some of my colleagues to cap services or to block grant the program, both ideas that would not make health care more affordable, but would instead leave some of those who need the program without it and shift the cost to states and localities. This would undermine the fundamental principles of the program, and I cannot express enough how damaging that would be to patients and my constituents. But we can all agree that there are ways to make the program more responsive on the financial end. Studies show that when the current federal formula for FMAP uses per capita income as a proxy to reflect a state's financial resources and Medicaid needs, it is a poor proxy for both. This misrepresentation sustains significant funding disparities among states taxed by the federal government while with serving the health needs of their low-income residents. And states like California that have relatively higher financial resources, but also relatively higher poverty rates, are misunderstood as having lower Medicaid cost pressures than they actually do. In fact, one study undertaken by California Common Sense, a nonpartisan research group in my state, found that by using a more accurate measure of poverty and need, California should be receiving a 15% higher FMAP rate. Dr. Mitchell, how does the current FMAP under-reimburse states like California who have higher Medicaid cost pressures than are reflected?
Well, GAO has done a lot of work in this area, but you know, with the current formula, they're only looking at the per capita income, so they're not taking into consideration the number of poor people in the state, the number of people eligible for Medicaid. None of those factors are taken into account.
Without this more accurate measure that looks at the financial, well, maybe I should just stop and say, does GAO want to respond?
Ms. Mitchell's correct. Our work has shown one of the ways that it plays out is you can have two states with the same per capita incomes, and the way it translates into the Medicaid program has a really different effect. For example, a state with a high number of disabled and elderly individuals is going to be struggling to finance their program more than a state that's primarily comprised of children and families.
Okay, thank you. So without this more accurate measure that looks at the financial resources and Medicaid needs of the state, states like mine, California, have worked with their healthcare providers to maintain a stable, functioning safety net healthcare system. One way they have done so is through our state's provider fee that is used to help pay for the non-federal share of their Medicaid program. Federal Medicaid law requires that provider assessments be broad-based and uniformly imposed, and federal laws and regulations guard against the misuse of provider assessments by states that seek to receive higher federal matching rates than statutorily allowed. In California, the provider community is strongly supportive of the fee, even non-safety net providers. The fee has been approved by CMS and is used right. Money that comes from the state healthcare system goes right back into it, targeting the providers who provide the most under and uncompensated care. Over the years, however, we have heard rumblings against the program. To be clear, cutting provider fees would hurt all individuals in the state, not just working families. Before the California fee went into effect, a dozen safety net hospitals were about to close their doors, not because they didn't have patients to care for, but because they couldn't afford to stay open. The provider fee has given them new life so that they are there in the community for both Medicaid patients, but also any community member who needs care. And with that, Mr. Chairman, I yield back the balance of my time.
Chair thanks the gentlelady. Now I recognize the gentleman from Missouri, Mr. Long. 5 minutes of question.
Thank you, Mr. Chairman. Ms. Yoakum, why is it that the current FMAP formula isn't sufficient for dealing with economic downturns?
A lot of it has to do with the timing and the fact that the data that, as Ms. Mitchell talked about, the data that are represented by the FMAP calculation, in addition to not being complete enough, it's also old. So when you're in a steady economic time or a time of growth, it doesn't cause a problem. It's during a downturn that the real effects take place, because the FMAP is reflecting economic circumstances that were several years ago. Does that make sense?
Okay. Have you assessed how well the prototype formula would have worked in these previous downturns?
We have. Our first effort to create a model like this addressed about 90% of recession-related costs. And where we found that it was lacking was for states who were slow to enter a downturn and slow to recover. And so then we adjusted the way that we end the assistance period based on states' activities and did some slight improvement. I don't think we calculated the percentage of costs covered since then, but we believe it's a pretty strong formula.
You believe it's what?
It's a pretty strong formula for assisting states with their financial needs.
Okay, my next question here is for you or Dr. Schwartz, whoever wants to take it first. What type of other policy proposals have been proposed in the past for replacing FMAP and improving financing the Medicaid program?
What types of policies have been proposed?
Yeah, what type of policy proposals have been proposed in the past for replacing the FMAP and improving financing in the Medicaid program?
There was at one point legislation looking at adjusting the FMAP during a downturn. I do not know how far it got in the statutory path.
Dr.
I know
Ford,
you've done a lot of work in this area.
MACPAC's just conducted a historical review of major reform proposals, and we're working on cleaning that up so that we can share it with the members of the committee and your staffs. Some of the ideas that have been talked about over the past 20 to 30 years include block grants, as has been stated earlier, per capita caps, capped allotments, and those are some of the proposals that we will be looking at going forward. But we will provide you an analysis of some of those ideas.
And how would those options change the incentives and disincentives facing states?
Well, they differ from each other in how they're designed, but in general, they change the nature of the relationship between the federal government and the states in providing more fiscal discipline, in limiting the resources, either in total or based on the number of enrollees or other mechanisms of that type.
Okay, so there would be incentives and disincentives for states. I mean.
Yes.
Okay, thank you. I appreciate your testimony here today. With that, I yield back.
Thanks, gentlemen. Now recognize the gentleman from New York, Mr. Engel, 5 minutes for questions.
Thank you. Thank you very much, Mr. Chairman. Mr. Hagg, I just have a couple of quick questions for you based on the issues you raised regarding my home state of New York. In your testimony, you noted past issues regarding reimbursement for developmental centers and residential habilitation centers. And in both of these instances, it was clear that both our state and CMS made administrative errors that resulted in overpayments for these services. And in both instances, all parties involved, including the state of New York and CMS, largely agreed with OIG's findings. Is that not correct?
Yeah, I think that's correct.
Yes. It's my understanding that following this report, New York and CMS worked cooperatively to both fix the problem in the future as well as agreed upon a financial settlement to resolve the issue. That's true as well.
That's correct, yeah. I mean, initially it was trying to fix the problem moving forward, and then it required some audit work looking backwards to figure out the scope of the problem, the extent of the problem, and then, yes, the state and CMS worked closely together to reach that settlement, yeah.
Thank you. Your testimony today also included the results of many investigations, and my reading of these reports would indicate that nearly all ended with cooperation between the states and CMS to resolve the issues at hand. Is that correct?
Well, are you talking about the audits involving some of the enhanced FMAP claiming areas?
Yes.
Yes. I think, I mean, I don't have a list in front of me, but for I would think most, if not all of those audits, CMS concurred with the recommendations that we made. I think in a lot of cases, the states agreed with our findings and recommendations as well. So, yes, CMS as the action official would work with the states to help implement those recommendations.
Okay. And finally, would you agree that most investigations on issues similar to New York's are addressed in a generally cooperative manner that improves the program integrity in the long run?
I'm sorry, could you repeat that again?
That the investigations on issues similar to the ones we had in New York, because as you pointed out, New York wasn't the only state, that those issues are generally addressed in a cooperative manner that improves program integrity in the long run?
Generally speaking, yeah. I mean, if CMS agrees with the recommendations we make in the states, then yes, there's a cooperative effort to try to help improve the program moving forward. I mean, sometimes there are disagreements where states disagree with the findings that we have or the recommendations we make. Sometimes CMS disagrees with us, but by and large, when there is agreement, yes, there is a cooperative effort to help improve the programs moving forward.
All right. Well, thank you. I just wanted to get that those clarifications on the record. OIG has done very good work, in my opinion, to ensure that reimbursements in the Medicaid program remain accurate, and certainly OIG has raised issues in the past, but it's clear that these issues are solvable and always nearly end with both long-term program improvement and an amicable agreement between the federal and state government. So I just wanted to get that on the record. Thank you, Mr. Chairman. I yield the remainder of my time.
Chair, thanks, gentlemen, and now recognize the gentleman from Florida, Mr. Billeracus, 5 minutes for question.
Thank you, Mr. Chairman. I appreciate it very much. I want to thank the panel for their testimony. GAO has listed Medicaid as a high-risk program for more than a decade. I'm sure you know that. The IG's office in 2015 Top Management and Performance Challenge Report has Medicaid fraud, waste, and abuse listed in the #1 spot. Mr. Hagg, this week the Energy and Commerce Committee sent a letter to the IG's office asking for additional information on Medicaid payments related to deceased beneficiaries and deceased providers. Do you know the size and scope of the problem, how much money is being wasted? Shouldn't be any money wasted as far as I'm concerned. What services or payments are being made, and why life status cannot be determined in a timely or accurate way? And I think it should be pretty simple, but if you could answer that question, I'd appreciate it.
Yeah, I don't have an answer to the scope of the problem or the magnitude of the problem. Over the years, we've conducted various audits going back a number of years where we would identify Medicaid payments that were made for people that were deceased. We currently have some ongoing work looking at a few different states, trying to determine for those individual states, I mean, it wouldn't be a national look, but for individual states, the extent to which payments are made for people that are deceased.
Well, why wouldn't we look at all 50 states in this case?
It's a resource issue. I mean, it's really, I mean, that's a lot of data to crunch and review, and once you have things that look like errors, there's specific work that needs to be done to look behind and make sure that we are actually talking about someone who is deceased. So it just requires a lot of resources.
Well, it's my understanding we've had spot checks before, and it just hasn't done anything. Why not a comprehensive look at the problem? I mean, as far as I'm concerned, it's a big issue.
Well, I don't disagree with you, and the thing that's always been interesting with that is you would think it'd be something that over time we would be able to get correct.
How do you engage with the states?
How do we engage with the
states?
states?
Yeah, with it, yeah.
Well,
to get the information necessary for the analysis.
Well, just like all of our work, we try to look at areas that we believe are higher risk, areas of vulnerabilities, whether it's across states or in specific states. We decide, once we see those vulnerabilities, to conduct audit work that would address those specific areas, those vulnerabilities. If we decide to audit a specific state, we obviously meet with the state and talk to them about the audit we're going to perform, the scope that it would entail, and the methods that we would use. And we work with the state to get the data we need to make determinations to fulfill our objectives.
How many states have you identified so far?
For payments for deceased bennies?
Yes.
Right
and how much money is involved?
Currently, I don't know the extent of the errors. We have ongoing work in 2 or 3 states. When that work's completed, we can talk about our findings more. Right now, I don't have any findings to report because the work isn't completed. You know, I know going back years, I mean 10 years or more, there would be audits conducted by us and other groups that would find Medicaid payments for deceased bennies. I think the amounts would vary from $1 million or $2 million here or there to higher amounts like 25 million or more.
Yeah, that's outrageous as far as I'm concerned. Okay, well, please keep me informed.
We'd be glad to do that.
Because I need to follow up on this. Thank you very much. I yield back, Mr. Chairman.
Thanks, gentlemen. Now recognize the gentleman from Indiana, Dr. Bouchon. 5 minutes for questions.
Thank you, Mr. Chairman. Medicaid is a critical program. I was a physician in my previous career. I'm still a physician, but now I'm here. But in my view, that needs broad reform, and we're talking about some aspects of the law today. In many states, having Medicaid does not guarantee access to health care other than through the emergency room, and that's true today, as it has been for quite a while. As the costs continue to rise overall in health care, more stress will be put on this critical program. One of the failures of the ACA is addressing coverage and not addressing cost. And without honestly looking at some of the things that are driving the cost and solving those, we're going to continue to be talking about coverage when we're missing the boat because it doesn't guarantee access. Price transparency for the consumer in healthcare, it doesn't exist. Quality transparency is getting better. The combination of those two is the value that you get from a service. Looking at tort laws, antitrust and stark law reforms, and many other things to try to help decrease the costs in our healthcare system will be imperative to the other things that we look at structurally within the Medicaid program. So and this question goes to Dr. Schwartz or Ms. Yoakum. Has anyone looked at Medicaid recipients and their ability to find access to a primary care physician other than through the emergency room? So for example, you have a Medicaid population. Has anybody surveyed them and found out the percentage of them that can't find a primary care physician to take care of them?
There are a number of different surveys that have been done to look at access for Medicaid beneficiaries. One is to using the National Health Interview Survey and asking a number of questions about access. Unfortunately, using that survey, we can't get state estimates, so some of the variables that would be important about how states design their programs, you can't tell. Another approach that's been taken more recently by a group of researchers at the University of Pennsylvania is to do what they call secret shopper and call and pose as a private insurance patient or Medicaid patient and to see what the access barriers are. And they do see some differentials, and in that study they were also looking at differences in fees and found that states that had higher fees in the Medicaid program did have fewer barriers for access.
There's another national survey. Again, we cannot get down at the state level, which is problematic, that from the perspective of the beneficiaries, finds that Medicaid access is comparable to that of private insurance with regard to initial primary care. And the difficulties reported in obtaining care get higher when you're talking about specialty care or behavioral health services in particular. Now, what we don't know is the frame of reference of those individual respondents. If they were previously uninsured, Medicaid may make things easier. If
Yeah,
they were
because I understand the study, but as amongst the community that I represent, we hear all the time about difficulty finding physicians, and we're hearing more about Medicare patients finding access to primary care physicians because physician practices are closed to those populations based on the low reimbursement rates. Mr. Hagg, when the state claim a higher federal matching rate than they're entitled, what is the process for the federal government to be made whole?
Well, specifically tied to the work that we performed, if the state agrees and CMS agrees, it could be a fairly quick process. In the next quarter, the state would return the
That's
funds.
the question. So the next quarter, the payment, it can be rectified?
If the state agrees that it's an overpayment.
Yeah.
Now, if they disagree, there's certain appeal rights that they have that they can go through. Once those appeal rights are exhausted and it's still determined to be a legitimate an overpayment and that CMS agrees with as the action official, CMS would issue a disallowance letter to the state. That may take several quarters to actually get the money back at that point then.
Okay, great. And Ms. Yoakum, obviously there's a trade-off between complexity and accuracy involved in alternative measures to determine and to allocate Medicaid funding to the states. Can you just briefly comment on that? And is there any non-complex, accurate way to do this, or it's a balance?
Unfortunately, there probably isn't. There is a trade-off, though, between how complex you want your formula to be versus how how simple it is to implement. I think really at the end of the day, it's a congressional policy decision of how important it is to be as equitable as possible across the states.
Thank you. My time's up. I yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from New York, Mr. Collins, 5 minutes for questions.
Thank you, Mr. Chairman. Let me explain perhaps a problem I have, and then we'll ask a little input. I'm from Buffalo, New York, Erie County, New York, one of the poorest cities in the United States of America, and hence one of the poorest counties with very high percentage of Medicaid. So it's my understanding there's about 13 states out of 50, New York being one, that force the counties to pick up a large piece of the state share. In 37 out of 50 states, the state picks up their share, the federal picks up their share, and that's it. And that reimbursement rates dependent on the state income level compared to the national average. In New York, and I think 12 other states, though, the state forces a big piece, as much as half of that state share, down to the counties, the 62 counties in New York. So New York being considered a wealthy state because of New York City, Westchester County, we're at the lowest level. We're reimbursed 50%. But in a poor county then, like Erie County, largest upstate county in New York, that share comes back to the county. We're only getting 50%. Yet Mississippi, which has the same relative income level, gets 74%. So you can see where, yes, it's a state issue perhaps, but I believe this reimbursement was to protect, if you will, the taxpayers of a poor state. Well, think of Erie County as a state. We're a very poor county, yet we're only reimbursed at 50% because of that. So my thought would be having a state like New York that is 62 counties that forces it back on the counties. We should have 62 different reimbursement rates that accept that. Erie County is a very poor county. And to put it in perspective, the county, little county, well, it's a big county, but our county share of Medicaid was, give or take, $120 million a year. $120 million. Our entire county property tax was only $110 million. 100% of our county property tax would not even cover our Medicaid portion. So we had to dip into our sales tax collections to cover that. And then everything else in our budget, from highways and all other services, jails, was covered by sales tax. So I think you can see the dilemma we have as being one of the states where the state is forcing substantial costs, what they call the state share, but in New York it's state and county share, and yet we're a poor county. So I guess the question, I don't know, perhaps to Ms. Mitchell, I have to assume it wouldn't be that hard to have 62 reimbursement rates, one for each county in New York. The data is easily available, I would presume. I know it would take a bill in Congress to say for those states, which push it back to the local level, we will look at each county as its separate entity and recalculate that rate. So I'm just trying to, and I know that's different than what we have now, but that wouldn't be that difficult to do, would it?
I believe it could be possible to do that, and unfortunately at this point those sort of decisions are made on a state level. States have a lot of discretion in how they design their program and how they fund their Medicaid program.
But if the state did like New York, though, you could then go back to the federal government and say, here's New York State's program, so in this case, let's recalculate for the 62 counties. I know it would take an act of Congress to do that, but I think you can sense my frustration as the county executive of a very poor county, being treated like we were Westchester County or Suffolk County or Nassau County, but we weren't, home to the city of Buffalo, the third poorest city in the United States. So would anyone else want to comment on that, or have you heard this argument from others? I mean, there's 12 or 13 other states that do likewise. A lot of people have no idea that it happens. So with that, I'll yield back the balance of my time, but, you know, my thought would be, if you could get Congress to move, the first question would be, how hard would it be? And I don't think it would be that hard to calculate 62 different rates for New York. Just press of a spreadsheet button, and there you go. Thank you very much, Mr. Chairman. I yield back.
Chair thanks, gentlemen. Now I recognize the gentlelady from Indiana, Ms. Brooks. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to the witnesses for your testimony. And I want to commend actually my home state of Indiana for taking the lead in developing a groundbreaking approach as what is known as Healthy Indiana Plan, HIP 2.0. And it's an innovative, consumer-driven health insurance program, as you know, designed to empower members to take personal responsibility for the healthcare decisions. And just as HIP 2.0 encourages individuals to take responsibility, FMAP should encourage states to take responsibility of their financial health of the state Medicaid program. I'd like to just talk about, because I think this is an important discussion on how we maximize the federal dollars to provide for the best health outcomes for those, our nation's most vulnerable populations. And Ms. Schwartz, last Congress, I joined a bipartisan group of colleagues from the Women's Caucus to urge the renewal of CHIP. And moving forward, I want to ensure that we continue to provide care for those roughly 8 million children and pregnant women around the country, including roughly 84,000 children in Indiana. MACRA extended CHIP through the end of next September, and the ACA increased CHIP's already enhanced FMAP by 23%. So under MACRA, the federal government's paying, as you said, all the costs for CHIP in 12 states and paying 90% of the costs in an additional 20 states. So last time that the MACPAC commented on CHIP, there was a 2-year extension. And now that there's a more in-depth examination, I hope the Commission's examining as to what degree a lack of a state contribution may affect the state incentives to ensure that Medicaid payments are appropriate and accurate. Can you comment on that?
Certainly. The Commission has a very aggressive work plan and is very focused and has committed to having a package of recommendations for Congress by the end of this calendar year, so that when Congress turns its attention again to funding for CHIP in the next Congress, that MACPAC's recommendations will be available. We're looking at many different aspects of the program: benefits, affordability, state administration, and financing. And all of these will fold into those recommendations. You can see that that will be on the agenda, consume a considerable amount of the Commission's time at every meeting over the course of this year.
And is MACPAC evaluating incentives in CHIP's current program financing?
Yes.
And what, if any, actions has CMS taken to ensure the accuracy and the appropriateness of federal and state payments?
I can't speak to what CMS's actions have been in this area, and I can check into that and get back to you.
Okay, thank you. Mr. Hagg, the list of top management challenges for HHS identified protecting the Medicaid program from waste, fraud, and abuse as the #1 challenge. When do you expect OIG report, the findings on this issue will be made public? And can you talk about, will your analysis review whether individuals whose medical services were financed at the enhanced matching level were actually eligible under the statute? And you talked about that a bit in your testimony. Can you expand on that?
Well, yeah, a few different things. One, the list of top management challenges is really to highlight for the department and others, external parties, the areas that we believe have large vulnerabilities. It doesn't tie to a specific report that we would put out to say specific problems have been solved or not. We have a body of work in Medicaid covering a lot of different areas, and the results that we find leads us to the conclusion that Medicaid's a high-risk area. So that's one thing. You know, as far as some of the enhanced FMAP rate categories, the one specifically you're talking about for the newly eligible population, we have some work ongoing. It's 2 different tracks, really. The first is some audit work that my team's doing. It's focused on states and the actions they're taking and claiming. The second track is being done by our Office of Evaluations and Inspections. They're looking at CMS's oversight and their responsibilities and the actions that CMS is taking. Anticipate that work being done sometime later this year. For the audit work, as early as, well, probably not before the end of this calendar year. For the work that focuses on CMS, probably no earlier than maybe late summer.
Is there a report that those of us who are working on Congressman Guthrie's Medicaid task force reform efforts, is there a report that you can point to where we can dig in on the waste, fraud, and abuse recommendations that OIG has made?
Yes. Well, one, you've seen the top management challenges. That'll lay out some of the things that we found. We have a semi-annual report that we put out, obviously, that highlights some of the areas of the bigger issues that have been identified. We have a compendium of unimplemented recommendations that talk about specific things that we think can still be done to help improve the program. And then beyond that, I'd be glad to try to provide some reports involving some of the bigger impact or higher risk areas that we've identified issues.
Thank you. Thank you all for your work. I yield back.
Chair, thanks, gentlelady. That concludes the questions of members present. There will be follow-up questions that we'll send. We'll send those to you in writing. We ask that you please respond promptly. And I have a use request from Mr. Schrader.
Thank you, Mr. Chairman. Just briefly want to recognize that Medicaid basically insures almost 40% of the children in the United States of America. So the impact of Medicaid on children should not be far from our minds. We've heard a lot of testimony today to that effect. So I'd like to ask unanimous consent to submit a statement from the American Academy of Pediatrics for the record, sir.
Without objection, so ordered.
Could I make just one final comment? Just like to keep the hearing in perspective. I appreciate the hearing. It's very timely, very important. At this point in time, it's pretty clear that there's been an uneven economic recovery. The good vice chair alluded to the fact that Medicare enrollments have increased over the last few years, and I think that's indicative of the fact that a lot of folks are struggling to keep up, despite the fact that unemployment is way down, and we're getting back our mojo, I think, as a country, but it's uneven at best. So Medicaid provides, I think, a very important role. I'd also like to point out that despite the complexity, and although we've heard a lot about some of the unclear rules, maybe from CMS and how the Medicaid money should be administered, and OIG and GAO have done a good job, I think, in pointing out some of the potential problems with interpretations of the program. No one's done anything wrong. So at the end of the day, I'd just like to point out that as far as the government program goes, Medicaid has the lowest improper payment rates of any federal health program. So let's keep it in perspective and talk about what we need to be doing. Last comment, sir, thank you for your indulgence, is that the real answer to driving the cost down is, again, quality-based reimbursement. That's how you get the biggest bang for the buck without hurting the people that need the program the most. So I'm hoping that we have that opportunity to talk about this and some of the other ideas that have come out of this hearing, and really appreciate the fact we've had this hearing. I'll yield back, Mr. Chairman.
Chair, thanks, gentlemen. Does the gentleman from Massachusetts seek recognition?
Yes, if I may.
Gentleman's recognized. 5 minutes for questions.
Thank God. Apologize for keep you all a little waiting, and then I got to catch my breath. Chairman, thank you for holding the hearing. To our witnesses, thank you for being here. Thank you for your testimony. Mr. Haga, I wanted to direct the first question at you, sir, if I may. One report that OIG has highlighted was a review of Medicaid claim adjustments in Massachusetts between 2008 and 2010. I wanted to take a moment with you to discuss the report. The main finding, as I understand, of the report was that our state overclaimed federal revenue around the time of the America Recovery and Reinvestment Act. So to start, the Recovery and Reinvestment Act was implemented in 2009. Is it true that nearly at the same time the Commonwealth implemented a new Medicaid management information system around then as well?
I believe that is correct.
And so is it correct that after OIG's findings were raised, the Commonwealth agreed to address the issue so long as CMS agreed with OIG's interpretation?
I'd have to go back and look at the report. At this point, I'm not sure I remember specifically exactly what the state comments were on our findings.
Okay, so if I jog the memory a bit and said that if OIG reported that the Commonwealth overcharged by $106 million, does that strike
Yeah, those are our findings for sure. I just don't recall what Massachusetts' reaction was to those findings.
So my understanding, sir, is that under OIG's interpretation, on the other end of the ARA period, Massachusetts would have been undercharged by $108 million. Does that part ring a bell?
Well, I don't know that our audit period looked through that far. I don't think it covered that much. We focused on a specific period of time and the adjustments the state made during that time period. If the state believed that at the end of the period the opposite effect would occur, then certainly CMS as the action official would work with the state to take that into consideration and correct it.
I appreciate that. I think the issue was that for looking at one time period, the state was overcharged the federal government $106 million, but looking at another time period was in fact overcharged by $108. And you're saying that you don't recall it, but would look.
Well, again, I mean, CMS is going to be the action official on this. I'm pretty sure that CMS concurred with our findings and recommendations. Now, without looking at that specific period that you're talking about or the state's talking about with an underclaim, I really don't know the answer to that, whether that's accurate or not.
Understood.
It really would be up to to CMS as the action official to look at the information. If they wanted to come back and ask us to look at it too, we would do that. But it would be up to CMS to try to resolve our findings and then the additional information, I guess, that the state has.
Great. And look, I come at this from the perspective of I agree with you wholeheartedly that program integrity is absolutely critical. And to the extent that the Commonwealth of Massachusetts, OIG, and CMS are able to work together to address the issue and did, I think it's fantastic. I think that's an isolated issue that ended up coming from a series of concurrent changes, such as a new information systems launch and at the same time a one-time stimulus. Hopefully those challenges are behind us. Ms. Mitchell, if I can ask, you noted in your report that the FMAP is utilized to determine the federal share of other programs in the government as well. I was hoping you can comment on this and lay out a few of them. The ways that FMAP is used for other programs.
Sure. The regular FMAP is used to determine the federal share of a number of programs, and the ones I'm recalling right now are the Temporary Assistance for Needy Families Contingency Funds and the Foster Care Title IV-E funding. And
so, ma'am, if our committee were to adjust FMAP funding in any way, we'd also be affecting the funding for those programs as well. Isn't that right?
I think it depends on how the legislation is written. If it's specific to the Medicaid program and you maintain the FMAP for the other programs, you could do that, or or it could apply to the other programs.
Okay. Thank you very much, and I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman, Mr. Cardenas, 5 minutes for questions.
Thank you very much, Mr. Chairman. Thank you all for joining us today. We appreciate your knowledge and your expertise on these matters. My first question is for Mr. Hagg. One report that OIG has highlighted was a review of federal reimbursement for family planning services in California, specifically in the San Diego area. I'd like to take a moment to discuss a portion of the report. In this report, over half of the improper claims were noted to be for visits that included testing for sexually transmitted infections. Is it true that after this report, CMS released guidance clarifying that STI testing is classified as family planning services for the purpose of calculating the FMAP?
I'm not sure that is true. I'd have to look back at that. CMS put out a letter to the state Medicaid directors in 2014. I probably would need to refer back to that letter. I know it clarified some previous guidance, and I think it revised some previous positions that CMS had taken. I should look back at the letter, but I think that would have been sexually transmitted infections would have been classified as family planning related, which would be billed, which should be claimed at the regular FMAP rate, not the enhanced family planning rate.
Okay, thank you. Appreciate that, Mr. Hagg. I also think it's also worth noting that as a result of OIG's recommendations, we've made programmatic changes to maximize program integrity moving forward. such as implementing an ICD-based reimbursement system. OIG's oversight has indeed provided worthwhile suggestions beyond STIs, which we are appreciative of. On the whole, I'm pleased that this discrepancy in interpretations between the states and OIG has been resolved. I hope that with this administrative issue resolved, we can continue to move past this and past the simple difference of opinions and towards further actions that strengthen Medicaid for all of our beneficiaries. I have another, my next question is for Dr. Schwartz. Again, thank you for joining us, Doctor. I'd like to ask you a question regarding upcoming work you noted in your testimony. In the summary section, you noted that MACPAC is now focusing intensively on financing and design questions associated with alternatives, such as block grants, per capita caps, and capped allotments. I was somewhat alarmed that the sentence went on to describe that it would examine issues related to these alternatives, specifically baselines, growth factors, and state contributions. Were these three items only made as brief examples, or does MACPAC plan to examine other effects of financing changes as well?
Yes, they're both design issues to consider, which are those that were mentioned in my written statement, as well as issues of impact. And our work plan and analysis will also look at impact on states, plans, providers, and beneficiaries. And another type of impact that we intend to look at is how changes in financing could affect other programs that rely on Medicaid to finance medical care for populations they serve, such as child welfare and special education.
Okay, so you are cognizant of what could occur as a result of these alternative financing mechanisms and how they would affect the system deliveries amongst all of our states.
Yes, that's part of our work plan.
Okay. One concern that has been raised is that alternatives to restructure Medicaid financing are often intended to reduce federal Medicaid expenditures. This subsequently places a larger burden on states and providers. I'm concerned this could have a negative effect on access to care. Will this consideration be included in the June report?
Yes.
Okay. When you say yes, to what effect, I mean, do you elaborate on that? Do you give examples? Do you extrapolate out on previous examples where we've done cuts in the past?
I think our analysis will do both. We certainly have experience from what states do now when facing constrained spending. We can use data to help us look at the impact of different assumptions. And so we can do both qualitative and quantitative analyses to look at those questions.
And are there potential examples where cuts have had negligible to beneficial effects on local output of services? And do we have examples that you could actually point to that have had negative effects in the past?
Well, states have sort of a defined toolkit in which they currently use to address issues of spending growth. They can address enrollment, they can address prices, payment rates, they can address covered benefits, and they can also do innovations to change the delivery of care. And all of those provide good examples for helping us think about future approaches to financing.
Thank you so much, Mr. Chairman.
Chair, thanks, gentlemen. I believe that concludes questioning now. I remind members they have 10 business days to submit questions for the record, so they should submit their questions by the close of business on Wednesday, February 24th. Good hearing, very complicated issue, important educate all the members and the public. Thank you very much for your testimony. Without objections, subcommittee is adjourned.